announcements while she gets back?
Sure, I think that's fine.
Okay. Hi, everybody. Thanks so much for joining us today. We are so excited to have Dr. Wong speak to us today about long hauler syndrome with COVID. I just wanted to go through a couple of housekeeping things before we get started and she jumps back on. Feel free to use the chat box at any time to ask questions for Dr. Wong or the panel. We'll address that halfway through. Additionally, I did want to just do a quick mention. Our next big event is our Lung Force Walk. It is going to be virtual this year, so you can join us hopefully throughout the month of June with fun fundraising opportunities, walk opportunities to get out anywhere and everywhere that you are to walk your way. So you can go to lung.org and search Lung Force Walk, and we will be there. We are walking throughout Southern California. More information to come, but you can register today to save your spot. Again, we're going to be starting all of our fun fundraising opportunities and challenges starting June 1st. With a really awesome celebration at the end on June 27th for top teams at AleSmith Brewery here in San Diego. So stay tuned. I'm also in the chat. We'll be posting the link to this website, but you can always just go to action.lung.org/San Diego Walk. So hopefully we will see you there. And as we wait, feel free, if you guys have any suggestions for our upcoming series, put them in the chat box. And we will get started here shortly when Dr. Wong comes back online. Tim, any announcements?
Yeah, while we're waiting, let me talk to you, to the audience, just a bit about what this series is. And first of all, welcome everybody. My name is Tim Morris, and I am on what's called the Mission Committee for the Lung Association. And our committee is a group of doctors and nurses and respiratory therapists and experts in governmental affairs and environmental science, et cetera. And it's a multidisciplinary group that got together to try to help the Lung Association to achieve its mission. And one of the items that we thought was important this year is to get good, straight information to you, the general public, about important things about your lung health, especially during the pandemic. So we organized this series called the Community Connections, or Have a Doc for Dinner, or Dinner with the Doctors, or whatever you want to call it, as a weekly series to try to get straight information to you about what's happening with the pandemic and what you can do to protect yourself. We have had the whole talk, actually the whole series has been made possible by a grant from the San Diego Foundation, and we really thank the San Diego Foundation for doing that for us. Our talk our series is actually in its final talk tonight, at least in the first rendition of it. And Julie, if you wouldn't mind putting up so that people can see the previous ones. But
Definitely. We're also just going to have a quick word by Tony Gwynn Jr. and then we'll and then I'll pass it back to you, Tim.
Why don't we do that? Okay, perfect.
All right.
All right.
The American Lung Association has been saving lives by preventing lung disease and promoting lung health in our local communities for more than 100 years. And today, achieving health equity is at the core of everything we do. We believe everyone should have the same chance at healthy lungs and clean air, but we all know that too often those families with the most to lose get the least access to quality health care, the finest hospitals, and even clean air. This is one reason we've launched Community Connections, free, interactive conversation with San Diego healthcare professionals and medical experts on the health topics most affecting our communities. My fellow board member, Dr. Tim Morris of UCSD, likes to call them dinners with doctors. For more information about weekly topics and more, please visit lung.org/events. I hope to see you there. The American Lung Association.
Oh, sorry.
Okay. Well, thank you, Tony. And thank you again for the Lung Association for making this whole series possible. I do want to tell you that we're now on the final talk for at least this first series, but that the previous talks are all available on YouTube. So this one's being recorded as well for YouTube. And we've talked about the adverse effects of smoking and vaping on your lung health, and maybe including some tools there to try to quit smoking. We've talked about how to maintain your overall health during the pandemic, how to keep your doctor's appointments, and how to keep yourself safe and continue to do the things that you should be doing to take good care of yourself. We had a wonderful talk from a vaccination scientist talking about how the vaccine was invented, what the different vaccines are, and what is the evidence behind the fact that they work and have relatively low risk. We had a talk about how to get vaccinated, what's the logistics of it, how do you do it if you haven't done it yet, and how you get your friends to do it, and what happens after you've been vaccinated. We had a really neat talk about the effects of the pandemic on mental health and stress, and linked together with that was a little bit that was really fun about how nutrition can help with handling stress. We had a nice talk about COVID-19 and how it affects people that have chronic lung disease, and because they're a particular risk for problems from that. And last week we had a wonderful talk from an infectious disease specialist about the latest in how to keep ourselves from getting the COVID-19 infection. This upcoming talk is going to be about what's called the long hauler syndrome. That has to do with the long-term effects of COVID-19. But before we get to that, I do want to take a moment to introduce you to the Lung Association resources. And right along the lines of the COVID vaccination, the Lung Association has put together a vaccine toolkit. And the reason for having this there is that there's all kinds of information on there about why people should get the vaccine and how to get it, et cetera. And if you haven't gotten vaccinated already, then I would urge you to take a look at this and see if there's something in there that you find resonates with you. And actually, it's a really nice conversation starters for people that haven't got vaccinated, if you know people that haven't. And maybe it's a way that they can look at it, maybe some of the straight up reasons why it's a good idea. And like I said, start the conversation off. In addition, since we do know that the damage caused to your lungs by smoking and vaping does make you susceptible to COVID-19, maybe now would be a good time to quit if you haven't quit already, or if you're a current smoker or vapor. And we have some toolkits on there, some helpful links on there that can help you a little bit along those lines. I did tell you back to our series now that we have already recorded a number of series, and this is going to be our final one. But we do have plans for doing a round 2 of this and doing a second series sometime later in the summer. And I would like to invite you, if you, for those of you listening to this, either live or if you're listening to the recording this on YouTube, to let us know if there are topics that you think would be particularly helpful for you to hear about fresh. We can also address some of the things we've already addressed. If you're listening to this live, why don't you go ahead and put your suggestions in the chat box, and we will write those down. And then Julia will be writing in the chat box here that you can see if it's a recording, an address where you can write in and put your suggestions in for future topics. Now for tonight, the program for tonight is going to be, we're going to have a panel of experts who are going to listen in just like you are to our talk, and then they'll be joining me later on in the presentation to have a bit of a discussion about our topic of interest. But let me, without any further ado, because I'm really anxious to hear a talk, let me introduce Dr. Angela Wong, who is one of my most longstanding colleagues and friends in the pulmonary field. We met actually shortly after I got out of my training, and she and I have been working together ever since. she's an expert in many things, and I have sought her counsel on any of a number of clinical situations, and she has made herself an expert about the long-term effects of COVID-19, and she's here to tell us about some of the things that she's learned as the focal point for our UCSD's efforts in this respect. So Dr. Wong, welcome, and take it away.
Thanks very much. I'm going to raise a symbolic glass of wine to you all. I wish I had one in my hand, but yeah, I'm really excited to be able to talk about this topic with you. This has really been a journey on which me and my patients are still on. And it's absolutely like a dialogue, I think, between patients and doctors as we learn from each other for this syndrome, which I think we're still looking for answers in many respects. So I'm gonna have to reload my slides because I got kicked off. So the title of my talk is Long COVID, and I subtitled it Fear, Hope, and Healing because really, as I mentioned, it has been a journey over the last several months for not only myself, but my patients. There's been a lot of fear. Hopefully at the end of this talk, you'll understand that there's not just fear, but also hope. And I think we're truly on the journey to begin some healing, but maybe not in the way that most people think. So I'm just going to get started here. So can you see this slide, Tim?
Yep.
Okay. So this is a story about a virus and its victim. So we all know now that SARS-CoV-2 is a respiratory, well, it's a virus that enters through the respiratory tract, but actually ends up attacking many different organs within the body. It does so by attaching to a receptor called ACE2. And this schema is just to remind us of all the different organ systems within the body that express ACE2 and can potentially be affected by the SARS-CoV-2 virus. So it's not just the lungs, but also the heart, the brain, the GI system. Really, it's ubiquitous. And that is going to be important when we start to talk about the sequelae of the long-term COVID infection. So I think we were all, many of us are familiar now with the story that COVID can cause severe life-threatening disease, primarily in elderly people with pre-existing medical conditions. And, you know, we've all seen the headlines of overwhelmed ICUs, overflowing ERs. But a secondary story or a parallel story that was going on at the same time was that the majority of patients suffer self-limited infections. And so most people, especially if you were young and previously healthy, it was thought that it was like catching a bad flu, and that within a week or maybe two, you'd get over it, you'd be able to get on with your life. But it became clear, even early on in the pandemic, that that wasn't always the case. And so this is a warning that came out from the CDC last spring, telling people that even in young adults who did not have any prior illnesses, that there were cases of people who apparently were not recovering quickly, and in fact, could also develop new symptoms several weeks after the initial illness. And shortly thereafter, the media followed suit with several headlines, which were very scary. Wall Street Journal, The Atlantic, New York Times, all talking about this post-COVID syndrome where people did not recover or develop new symptoms, as I said, after the initial infection. And it seemed like people were staying ill, not just for weeks, but months after their initial illness. So before I move on, I just want to kind of review some of the terminology And that has caused some confusion because people call this syndrome by many different names. A lot of people refer to it as long COVID-19. In the medical literature, you'll see something called PASC, P-A-S-C, which is post-acute sequelae of COVID. It's also called post-acute COVID, persistent COVID-19 symptoms, and COVID-19 syndrome. These are all terms that you'll see not only in the press, but also, as I said, in the medical literature. And this has caused some confusion because not everybody's always talking about the same thing. And so that's made it hard to study in some respects. But there is some organization coming out of all this chaos. And so this is a figure that I got from a recent Nature article, and which kind of goes over the timeline we think now of the acute and then post-acute COVID infection. So there's the initial exposure where you're infected with the virus. After that, we are able to detect the virus in your nasal swab. And then the viral positivity actually goes away after a while, but for you to be diagnosed with post-acute COVID, we're really looking for people who have symptoms after 4 weeks, so after 30 days. And we're further subdividing that into subacute, which is that period of time between about 1 month to 3 months, and then what we're calling truly long COVID, which are the people who are remain symptomatic from 3 months and ongoing. And we have patients that are still symptomatic 1 year out or more after their initial infection. Not surprisingly, given all the organs that COVID can infect, the symptoms that we're seeing in our post-COVID patients also run the gamut. Everything from fatigue and decline in quality of life to muscle weakness, joint pain. These are very debilitating symptoms in some people that have caused people to lose their jobs, that have caused people to not be able to return to the lives that they had before their illness. In many people, they have persistent shortness of breath or cough. Some people have persistent oxygen requirements. We're seeing a lot of anxiety as well and depression, perhaps in part due to the fact that people are not getting better. So that obviously leads to a lot of emotional distress, but also sleep disturbances in some people, especially those who have been hospitalized or who were severely ill in the hospital. We're seeing symptoms consistent with post-traumatic stress syndrome. A lot of people probably have heard about the brain fog that happens. This is real. People have problems remembering phone numbers. They have problems remembering their addresses. I had a patient who literally went to the store 3 times because he couldn't remember that he had already bought us an item and kept going back to the store to pick it up. Headaches are another common symptom that we see. In terms of the heart, people reporting palpitations and chest pain. We're seeing some increases in blood clots as well as kidney disease, not so much. I've also seen reports about hair loss. I have to admit, I have not seen this personally, but it is reported. And you don't have to have all of these symptoms. Some people have a few, some people have many. Really, there's a really wide spectrum of the symptoms that people are experiencing post-illness. So who is at risk for developing long COVID? The short answer is everyone. It's not just in patients who were hospitalized with severe pneumonia or who required oxygen or who were intubated and on a mechanical ventilator. We are seeing patients who had mild disease, who had moderate illness, who never were hospitalized at all. And so because of this, the patients who develop long COVID tend to skew slightly younger. And in contrast to the patients who are requiring hospitalization, there's a slight female predominance. And so I thought I'd just share a little bit of what we've been seeing in the pulmonary post-COVID clinic here at UCSD. We've seen actually now over 100 patients so far since the beginning of the year. And what this graph is meant to show is that most people actually don't have pre-existing medical conditions. Some people have diabetes, some obesity, hypertension, coronary artery disease. These are some of the pre-existing conditions that we were picking up in people who were requiring hospitalization and had putting them at risk for severe illness. But in the post-COVID or the long hauler population, many of the patients, as I said, were previously healthy. We're seeing athletes, we're seeing vegetarians. I mean, we're seeing people who previously followed a very healthy, active lifestyle who have been now afflicted with this syndrome. It's kind of interesting here in San Diego, a lot of the reports that have been coming out in the literature have focused primarily on Caucasian and African-American population. Here in San Diego, obviously we have a large Latino population, and in our clinic at least, if you look to the far left, so I'm just going to try and circle here, we actually have a large number of Mexican and Mexican-American patients, and they actually form a sizable number of the patients that we're seeing post-COVID. Also Filipino, which is here in the purple, and then smaller numbers of African-American. Right now, a large number of people actually don't report their ethnic background. So this data, is a little skewed, but this kind of, I think, gives you a flavor for what we're seeing here in the clinic. Okay. Now, if I can get rid of these. Okay. Yes, okay, it worked. All right. So again, the symptoms that we're seeing are primarily fatigue and shortness of breath. Actually, in our patient population, not so much altered sense of taste and smell, that people are thankfully recovering those, mainly by the time that we see them. We are seeing a lot of muscle and joint pain as well as weakness and cough. But I just want to alert people that, when you're reading these studies, one of the things I've noticed is the report, and this may be obvious, but you report on the things that you ask, right? So if you're not asking about certain symptoms or about certain syndromes, then it will not appear in your literature or your graph. Because as it turns out, one of the other things that we're seeing here in clinic, is addition to the respiratory issues and the heart rate issues and the fatigue and the muscle pains, we're seeing a lot of reflux. And that's something that's just starting to come out in the literature. And I have no idea why this is, but this seems to be a common sequelae of the COVID infection that we're seeing, not just in our clinic, but also in clinics around the country. And so this is something that we've been sharing. We have a Southern California consortium that meets pretty regularly. And this is one of the things that's come out in our own conversations, but not necessarily in the medical literature. So I think I'm just going to take some time now to actually just run through some of the more common symptoms and then what we're doing for them. So as I mentioned, large number of reflux. There's actually a couple different kinds of reflux, right? So in addition to typical heartburn or what we call gastroesophageal reflux, there's also kind of reflux that we call LPR, which is Laryngopharyngeal Reflux. And basically it's just stomach acid in the throat. So we see symptoms from reflux, not just from the esophagus, but also higher up in the throat. And the stomach acid or reflux can also actually get down into the respiratory tree and all the way up into the sinuses, where it can cause like sinusitis. And some people think they have allergies. but it's actually reflux. So most of the drugs that we have to treat reflux don't actually treat reflux, and that's a problem. Most of the drugs that we use actually just block acid, and that doesn't actually prevent reflux, and that's something that's important to remember. So we can decrease acid, but really what works the best to prevent reflux is actually modifying your diet and lifestyle to remove or eliminate the triggers of reflux. We've been seeing a large increase in alcohol consumption during the pandemic, I mean, for obvious reasons, but alcohol actually is a very strong trigger of reflux for multiple reasons. And so we always ask our patients to try and abstain from alcohol while we're treating them. Carbonated beverages are another source of trouble. You're drinking acid when you're drinking bubbles, and then the bubbles make you burp. And every time you burp, you're refluxing. And every time you're refluxing, you're sending acid and digestive enzymes up your esophagus, and again, possibly into your respiratory tree and sinuses. So those are probably the two things that we really stress. We try to get people to eliminate caffeine, and interestingly enough, caffeine is probably the hardest thing to get people to eliminate from their diet. So being pragmatic, I usually recommend that people drink no more than 1 cup of coffee a day. But, and this really seems like a really list that it's aimed to take out all the fun in life, but fried food and spicy foods also trigger a lot of reflux. So these are all things that, you know, we ask patients to do and things that they can do to help themselves and either decrease or maybe even hopefully avoid the need for additional medications. One thing that seems to be working really well that's been coming out through just kind of practical experience is something called Gaviscon Advance. It's not something that's made in the US. So if you go to your Rite Aid or Walgreens, you will see a medication called Gaviscon. It's available over the counter. Here in the US, Gaviscon is just an antacid. But in the UK, Gaviscon Advance is actually a seaweed-based product that makes a raft. And literally it's a raft that kind of floats on top of your stomach juices and actually blocks reflux, right? So again, I was saying that most of the drugs that we have don't actually block or prevent reflux, but Gaviscon Advance is something that looks like it can actually prevent reflux. You take it after meals, you can take it before exercise, which can also trigger reflux in people. You can take it before you go to bed. It's a homeopathic product, which a lot of people like, because obviously, you know, a lot of people don't want to be on a lot of medications, so they're looking for more homeopathic ways of treating their illness. So it is something that is readily available online. You do not need a prescription for it. And again, we're having a pretty good success with this medication. So obviously I'm a lung doctor and I work in a pulmonary clinic. So I'm going to spend a little bit of time then about shortness of breath, which is probably one of the more common symptoms that people come into clinic with. There's different kinds of shortness of breath, depending on the cause of the shortness of breath. Other symptoms that people might come in with, they often will describe the feeling of chest tightness, of not being able to take a full deep breath. And many times you will have a cough. So I'm just going to take a moment here just to talk about the role of a post-COVID clinic. So one of the things that we see that happens sometimes is that in patients who have post-COVID symptoms, and when they go to a clinic that perhaps is not as experienced in seeing patients with post-COVID, that it sometimes can lead you down the wrong path in terms of thinking of the differential or trying to work up the causes of what might be going on. The fact is that, just because you're having shortness of breath, chest tightness, or cough post-COVID doesn't necessarily mean that what you're experiencing is due to your prior COVID illness. And I think it's really important for people to remember that you still need to do a comprehensive workup for patients who are presenting with these symptoms, just as you would for somebody who'd never had COVID before. And not to let the post-COVID or that history of COVID kind of skew your perspective, because that can often lead you to eliminate potential diagnoses that you would miss. That being said, what are the illnesses that we are seeing in people who are presenting post-COVID? We're seeing a lot of asthma. So COVID is a respiratory virus. Many respiratory viruses can trigger asthma. Most of the patients that we're seeing who present with this kind of asthma type of illness don't have the classic symptoms of wheezing. Instead they report the chest tightness and the cough. Often their lung function studies are normal. While they do respond to inhalers, we're having to take a slightly different tack in these patients because many of them, as I'll get to in a few minutes, suffer from this, what we're calling this dysautonomia syndrome or rapid heartbeat that can be very debilitating. And some of the asthma drugs that we traditionally use can actually cause rapid heart rate, can actually cause anxiety. So we're having to kind of adjust our more classic or typical regimens to try and avoid some of these other side effects. Most of the patients that we're seeing with asthma have actually either had childhood asthma or have a close family member with asthma. I would say about 90% of the time, we're able to find some kind of link or predisposition for developing asthma, but not always. And again, patients are not presenting with the more typical symptoms of wheezing that other asthmatic patients have. The other common thing that we're seeing in our patients, especially for those who were actually hospitalized with severe pneumonia, oftentimes requiring high flow oxygen, or if they were severely ill, being mechanically ventilated or requiring intubation, is that they have had now this lung inflammatory syndrome that we call ARDS, or which was like your lungs literally are just burned with this huge inflammatory syndrome. But as a result, you can have scarring. And so what we're seeing in some of these patients is that they're presenting with persistent scarring, something called organizing pneumonia. Fortunately, although we don't have great medications for this, patients do recover over the next several months. So that is good news. Interestingly, we're also seeing what appears to be respiratory muscle weakness. So again, remember, this viral infection can attack multiple organs within the body. It can attack your muscles. It can attack your joints. For people when they're sick, right? They could be bedbound, especially if they've been in the hospital. And it's not uncommon after these kind of severe illnesses to be weak. But it also, for some people, seems to be affecting their respiratory muscles. And that can lead to the sensation of being short of breath because it's simply harder to breathe. The other thing that we're seeing is that many of our patients are presenting with anxiety. And that's kind of more of a chicken egg thing. It's not clear in some cases whether the anxiety is causing hyperventilation, which is causing shortness of breath, or it's the shortness of breath, which is causing the anxiety. And sometimes it's a little bit tricky to unravel in some of our patients. So I'm just going to spend a little bit of time now on what we call work of breathing, or how we breathe, because this has a direct bearing on some of the tools that we're trying to teach our patients then to deal with the shortness of breath. So it turns out that the main muscle of respiration, of inspiration, I say, so when you take a deep breath, is the diaphragm. So this is this muscle that sits at the bottom of the rib cage here. And when this muscle contracts, it descends and your chest will open up. And some people might refer to that as belly breathing, because as your diaphragm descends, your belly comes out and your rib cage opens up. Now, if I were to ask you to, jump up and run across the room or you to sprint someplace, you would need to breathe a lot faster, a lot harder. And so at that point, what happened was that you would call in these accessory muscles. And so these are these small muscles here up in the neck. They attach to your clavicle. And so when you're working hard to breathe, they will help to pull the rib cage up. So they're an accessory muscle, they assist, and so really help you breathe harder and faster when you need to. The problem is in our post-COVID patients, many of them are using these accessory muscles, so these little muscles here in your neck to breathe, and they're not using their diaphragm. Again, whether this is because of anxiety, respiratory muscle weakness, we're not entirely clear at this point, but there are tools that we can do to help teach you to breathe better and easier. Okay. Clear. Yes. So, sorry. So here we go. So what we're focusing on is a technique called box breathing. And if you've ever done yoga before, it's called Samapriti Pranayama. It's a sequence where literally it's mindful breathing. So I'm just going to have, if you're, see, now I'm going to have people kind of sit up. I can't see you, so you sit up and put both your feet on the floor and try and sit up straight. Maybe do a couple of shoulder shrugs and just really try and relax your shoulders, okay? So first thing I'd like you to do now is just to put both hands on your shoulder, okay? And take a couple of big breaths in and out through your mouth. And when you do that, you should feel your belly moving because your diaphragm's contracting, but you shouldn't feel your shoulders moving at all, right? So imagine now that you're a post-COVID patient and you're breathing and you're at rest. You're not running anywhere. Hopefully you're not stressed. But what's happening in these patients then, and you can see this actually even on a video exam, that they're using their shoulders to breathe. And so they're literally hunching their shoulders up and down as they're breathing. That is a lot of work. And it's tiring because again, these are little muscles that were not, that were never meant to be the main muscles of respiration. Okay, so if you're sitting up, I'm gonna have you put both hands on your thighs. Just try and relax your shoulders now. And I'm gonna have you close your eyes. And the idea with box breathing is that you're going to take a breath in, and I want you to count to 4. So inhale over 4 counts. 1, 2, 3, 4. Now hold for 4, 3, 4, and then exhale for 4. 1, 2, 3, 4, and hold for 4. 1, 2, 3, 4. Part of what this does then is to establish awareness of breathing. And so part of this is to try and teach the patient, or actually anybody can do this anytime you're anxious, to try and relax and think about how they're breathing. And then the next thing we're going to do now is we're going to repeat the box breathing, but I'm going to have you put one hand on your chest and one hand on your belly. So now we're going to repeat the box breathing. And as we inhale, you should feel your hand, both hands, come out simultaneously. So both your rib cage and your abdomen should expand at the same time. So, okay, let's try this. I wish I could see people, but okay. So I'm going to have you close your eyes, one hand on your chest over your sternum, one hand on your belly, okay? And then we're going to take a breath in, 1, 2, 3, 4, hold, 2, 3, 4, exhale, 2, 3, 4, hold, 2, 3, 4. And the idea now is that both hands should be coming out at the same time. If they're not, we ask patients to really focus on moving that belly hand, really trying to focus on using the diaphragm to breathe and feeling that expansion of the belly along with the rib cage as they're breathing. And we have them do this several times a day. Okay. Hope you're all feeling a little bit more relaxed now, that little breathing exercise. This is a website that we often refer our patients to. It's called Stasis. It's free. It was developed by the folks over at Mount Sinai over in New York. Again, it has breathing exercises that you can do, and it has coaching available. Another website that we're using is the Johns Hopkins. This actually has a YouTube demonstration, but this again is kind of what we were practicing just a few minutes ago. It's just the belly breathing. In our patients who are hospitalized and who are still severely debilitated, we actually have them start lying on their backs, as in this demonstration here. Because literally in some patients, having them do it even in a sitting position is too much. Gradually, as patients get stronger, we have them progress to a sitting position and then also to standing. Okay, I'm going to spend a little bit of time now talking about the rapid heart rate. The fancy name for the MDs in the audience is dysautonomia. Some of you might have heard of POT syndrome, which is refers to this orthostatic intolerance. And basically what we mean by that is when you stand up, your blood pressure drops and your heart rate goes up inappropriately, right? So that's a syndrome that was actually well known before post-COVID. But it turns out that in some of our post-COVID patients, they seem to have this predisposition to that. And literally, you can have somebody come into clinic and you can measure their heart rate when they're sitting and have, then again, when they stand, and simply by going from a sitting to standing position, their heart rate will increase by 10 or 15 beats and they'll get short of breath and dizzy. Most of these patients, they do not suffer a drop in their blood pressure. And what we think is happening is that their blood is inappropriately pooling in their legs. So normally when you stand up, your blood vessels contract to push the blood back up to your heart, where it should go. But for some reason that seems not to work very well in our post-COVID patients. There's multiple different ways of treating this. Here at UCSD, we do work with a cardiologist, and exercise can help. Not the traditional exercise program, but something tailored to try and avoid making people more shorter breath or increase their heart rate too much. And so we encourage non-upright exercise, like using a recumbent exercise bike. Swimming is actually great for some of these patients. There are some drugs that we use, beta blockers or something called ivabradine. Yeah, this would all be part of a comprehensive treatment program for the heart rate. The other symptom that is really debilitating for our patients is what has been termed brain fog. Literally, as I was saying earlier, people, their short-term memories is gone. They have problems remembering a simple task. So it's basically, we're trying to help people retrain themselves to develop tools to try and cope and get through this process, because it does get better. And that's one of the messages I do want to send to patients if you're listening. It does get better. It will take time. And in the meantime, what we can do is to help you develop like tools or workarounds that can help you get through this. There is a program called Cogsmart, and I don't think we have time to look at the video, but if you type Cogsmart, you will come up with this program that was built by a neuroscientist here at UCSD, and there's actually an app that you can download on your phone for this. Okay, I do want to spend a little bit of time talking about the fatigue, anxiety, depression, and sleep disorders that we're seeing. These are very non-specific symptoms. It can be really, and obviously very distressing for people, because these are things that really impact your quality of life, right? So if you're feeling tired all the time, anxious, you can't sleep, and it's depressing because you're not getting better. You don't know when you're going to get better. Sometimes it's due to some of these other issues that we've just been talking about, like the shortness of breath, the asthma, maybe the rapid heartbeat. But again, it's important to keep an open mind, because people still can have thyroid problems. They can have anemia, which is often seen in post-COVID. So it's really important to do a comprehensive workup and not just assume, oh, you have post-COVID and therefore you must be anxious. Because often there is a physiologic reason that we can find that we can treat and help you to feel better. That being said, there's no question that there are some patients who do experience post-traumatic stress disorder, especially if they had a severe illness requiring hospitalization. There's also, I think, not so much now as people are being vaccinated, but in the first few months and after our surge in December and January, there was a lot of social isolation, right? People were stuck at home, and stigma. People were literally being ostracized because they had COVID, and that was really, really hard to deal with. Okay, I'm just going to throw to talk a little bit about pulmonary rehab, because I think, at least from a lung doctor standpoint, it's an essential component of recovering from COVID. In the past, we have used pulmonary rehab for patients who had COPD and other chronic lung diseases, but it turns out that pulmonary rehab is having a really significant benefit for our patients with post-COVID. We've had to adapt our exercise protocols, as I mentioned, especially for our patients who perhaps have that post-COVID tachycardia or rapid heart rate syndrome. But getting people back on their feet has turned out to be important, not just, I think, from a physiologic standpoint in terms of, helping them regain muscle strength and get stronger, but it's been really important also from a social aspect. And I think, again, what we were just talking about, people feeling heard, right? People feeling that they're being taken seriously. Because I think when post-COVID was first being diagnosed and talked about, a lot of patients felt like they were not being believed. Yeah. Okay. So we're still learning. There's a lot that we don't know. And so I really like this quote from William Shakespeare, who's probably the ultimate storyteller. In many ways, we're just at the beginning of this story, and we still have a long ways to go, but this is a journey absolutely that requires a very intimate, I think, relationship built on trust between the caregiver, and that could be the physician or whatever clinician is working with you, and not just the patient, but your family, your friends. I mean, obviously, post-COVID affects everybody. So where are we now? So these are the latest numbers I got as of a few days ago. And this is kind of to give some kind of a perspective as to what are we facing in terms of our post-COVID. So there've been, about 32.5 million people now diagnosed with COVID. Again, a lot of the press and a lot of the news has been focused on the people with severe illnesses, and obviously, tragically, nearly 600,000 people who have died. But as we, slowly return to normal, and as our population is increasingly vaccinated, dealing with our post-COVID patients is going to be an ongoing problem. And just think about the enormity of it, right? Out of 32.5 million people, if just 5% of people have post-COVID, that's still a huge population that are going to be affected. And these are people, again, who were in the prime of their lives. So it's not just their illness, but the socioeconomic cost, people who have not been able to go back to work, or who return to work maybe at a reduced level, right? So they're no longer able to provide for their families. These are people who are athletes who had active lives, who now are just struggling to return to some kind of normalcy. So fortunately, the NIH has launched a new initiative to study long COVID. UCSD and several other institutions all across the country have applied to study this. So obviously, we're hoping to get answers as to what could be causing this and help us to develop new treatments. And so finally, I just want to end with the fact that in the end, we're healers. And I think, I trained during the AIDS crisis, so that kind of dates me and tells you how old I am. But some of the issues that we face then are similar to what we're facing now. At that time, we were faced with this devastating fatal illness, for which at that time we had no cure. But it really required us as clinicians to dig deep and just remember with it that sometimes, even though we're not able to cure people, that doesn't mean that we're not able to heal. And when we talk about healing, it's important to remember that we don't just treat disease, we're treating a fellow human being. And that means paying attention to not just their physical well-being, but their emotional, intellectual, social, and spiritual self. So, I talked about in the beginning that while there may be fear, there is absolutely hope. And we are here with you on your journey to healing. Okay, I can't see anybody, so I'm just going to end right there. And I hope you have some questions, because I went through a lot, but I know I skipped over a lot. So please chime in.
Well, thank you very much, Dr. Wong. That was a wonderful presentation. We're going to be joined now by our panel of experts. So we have Dr. Welsh and Dr. Montgrain and Dr. Akathota are going to join you, other fellow members of the mission committee. And while they're logging on, I wonder if you could ask you one question to start the discussion, and that is, first of all, we certainly were entertained by your hand motion simulating a boat. I think I'd like to learn how to do that someday, or a raft, I mean. But perhaps more important, what if there are people who have not been diagnosed with COVID and have some of these types of symptoms that you have, and wonder whether it's some other medical illness? As you said, this is long after the COVID has come and gone. What advice do you have for them if people say, gee, I'm having brain fog, or I'm having headaches or muscle aches or something like that, the other things that you said, what would you suggest that they do?
Yeah, that is a super great question, and one that I consciously ignored, because it's been a really difficult question for many of us treating post-COVID patients, because as you know, Tim, in the beginning of the pandemic, we didn't have tests. People didn't have access to testing. And so most people got sick and we never knew if they had COVID. I try to give people the benefit of the doubt, but it's hard, you know, and we've had these issues with other, oh, thanks. So we've had these issues with other illnesses like Lyme disease, you know, EBV, for instance, other illnesses which seem to have, which seem to cause persistent symptoms or long-term sequelae. Yeah, that's a non-answer, but.
Well, would you recommend that they get, you know, a test for the antibody or something like that, or should
yeah.
they
So you know, the antibody levels can go away right after a few months, and so we're finding, you know, we have patients who have presented with symptoms that sounded like COVID. They have negative antibodies. We just don't know. Yeah.
Yeah, I know. In my clinic, I get that question quite a bit, and
right.
Part of the problem is the non-specific nature of complaints, you know, especially coming off a year where people have been so socially isolated, you know, if they say, you know, have trouble sleeping, or they, you know, anxiety or something like that. I wonder whether that's part of the social problem of the pandemic.
Exactly. So that's why I think it's important to get a comprehensive workup, because it may not, even if it were a sequelae of COVID, it may not necessarily be due to the infection, but it's just some other process that you happen to have. Like, you know, we are picking up sleep apnea. We are picking up, you know, other things that can cause many of these symptoms.
So for the other doctors on the call, is that a common situation where people are having some complaints and it comes up that this could be undiagnosed post-COVID syndrome, or if they have that, are they coming to you with that specific complaint?
Yeah, I would say yeah, Dr. Morris, that I've had several people come to clinic thinking that they might have missed getting their diagnosis. You know, they felt poorly. Maybe they were feeling ill during a time when testing wasn't quite as available last year, or, you know, they had something that sounded all the world like COVID, but their test might have been negative, and just saying, you know, I just haven't felt right since, you know, I had these, you know, few weeks of viral symptoms. So, you know, particularly my asthma patients that I see, I've had a few who have come in and said, you know, sometimes with confirmed COVID, sometimes with something more non-specific, saying, you know, something is different now. My asthma is worse. And it's kind of hard to pin down.
Yeah, I would add to that. It's definitely a frequent complaint is, you know, I think I had COVID in the past and now I have these residual symptoms. In fact, I just saw a gentleman today with an exact complaint like that, and we got his symptoms and his need for oxygen, which was kind of a surprise, were enough to prompt a CAT scan, and he had organizing pneumonia on his CAT scan. And then we're left wondering, well, is this what we call cryptogenic organizing pneumonia, which means we don't know what caused it, unknown cause is cryptogenic, or is this related to COVID? And does it matter, or do we treat them the same? And those are the kind of challenges we are faced with almost all the time now.
Mike, are you seeing this in kids? Is that a common thing that you think about as a possibility?
You're muted, Mike.
Mike, if you're talking, we can't hear you.
All right, yeah. Fortunately, we're not seeing this problem in kids yet. I think parents sometimes wonder about it with their kids flare their asthma. They wonder if maybe COVID was a trigger, but I think most of the time it is not. What I would like to ask Dr. Wang is the asthma that you're seeing in the young adults that where they're problematic with their asthma, are they responding to the treatment you normally do that when people do need further like asthma controller medicines, are they responding the way they normally would if they didn't have COVID as playing a role?
Yeah, so I kind of alluded to this, you know, and a lot of patients were avoiding the beta agonists simply because of the concomitant tachycardia, and also this many patients overwhelming anxiety. So we don't want to make that worse. So we're using a lot of ICS and LAMA and Zopanex. So that's kind of the cocktail right now. Yeah, it works. Mm-hmm. And that chest tightness, you know, they have chest tightness and they get funny pain. I didn't talk about this a lot, but I think it's because maybe, I know I talked to you about this, Praveen, but like their lungs are kind of hyper expanded and they're breathing like this and they get funny pains in their chest, I think, which is maybe rib cage. And then we give them the ICS and the LAMA, even though they don't really have obstruction on their spirometry, and things just kind of seem to relax.
So for those of us listening in that aren't experts in what you're talking about, are you talking about giving them the animal of a llama?
Yeah, you know, llama therapy, if you hug a llama. So it has there are two different classes of what we call bronchodilators, so medications to help open up the airways. And one of them is can be, not always, but can be associated with an increase in your heart rate or anxiety. And the other class is not. So, yeah.
So no hugging llamas.
You can still hug
a llama. No, you can still hug a llama.
So I do have another question that came up actually in one of our previous meetings, and that is that there have been at least some scattered news reports about vaccination helping with these symptoms. And I'm wondering whether that's a psychological thing or is there something to that?
I think your guess is as good as mine. They're all anecdotal reports, right? So it could be just, yes, I ate a carrot and yes, I feel better, or yes, I got my shot and I feel better. I mean, people do get better. I mean, they do get better. That's the one message I do want to get out to people, that you do get better. And so sometimes it just may have been a lucky coincidence. We just don't know.
Is there an immune rationale for that? Maybe Praveen can tell us.
Yeah, I mean, it's that's a tough one. I don't think there is a logical, you know, like point A to point B immune rationale for why somebody might feel better from post COVID. But let me speculate for one possibility. You know, perhaps there's some residual viral replication at a low level that's being, you know, that's being cut off by being immunized and having some increase in spike protein antibodies. But that's completely speculation, completely.
Let me ask maybe the other side of that question is, let's suppose that you had somebody, or there was a patient, maybe somebody listening in now, who suspects that they do have the post-COVID syndrome. Would there be any part of that would be a good reason to not be vaccinated? Say, boy, I don't want to stir things up again or something like that.
No, we're encouraging them to get vaccinated. There was some concern early on when the vaccinations were starting, especially in patients who had that kind of overwhelming inflammatory syndrome, the acute respiratory distress syndrome, or severe pneumonia, that maybe we would trigger that same inflammatory response, but that doesn't seem to be happening.
Right. Yeah.
And again, as Dr. Akitoto was saying, we're not clear yet, you know, whether some of the symptoms are due to ongoing low level of viral replication, or whether this represents an autoimmune response, for instance. There's so many questions that we still have. So.
Yeah, I haven't personally seen anyone who got vaccinated and then presented with more of these post-COVID syndromes, but I don't know if anybody else has had one of those cases. Doesn't sound like a lot of head shaking. No. Okay, good. So maybe my final question, and I'll leave it open to the panel if they have questions, is how does this compare to? I know that there's a post-ICU type syndrome, which happens, you know, with people that are gravely ill, and then they're coming out, and some of them experience respiratory symptoms, and then some of them experience the type of thing you're talking about. Is this the same thing, or is it a different deal?
It may be a little bit of both, particularly people who were critically ill. I would say probably some of both in those people, but for folks who weren't hospitalized, I would say it's probably a different deal.
Yeah.
Great. Well, I think we're a little bit over time, so let me thank the panelists, Dr. Agathota, as always, Dr. Moncrief, Dr. Welsh, thank you very much for your input. Thank you for your participation in this entire series. Dr. Wong, especially thank you to you tonight for such an excellent presentation to finish off our first round of these presentations. Thank you to the audience for showing up for this, and thank you for listening in. As I said before, we have done this as a small series, and this very committee is going to be discussing over the summertime about whether to do a second one of these series. And if you have some input, something that you'd like to hear about, then please do let us know either in the chat box now, or Julie had put up her email address earlier so that you can send it to us. But in the meantime, please stay safe, stay healthy. Thank you for tuning in, and we'll see you later. Thank you.
Thanks, everyone.
That concludes tonight's Community Connections. Thank you, everybody, for joining us, and have a wonderful evening.